Session, I would like to invite Professor Jyothi Rameshchandran, Professor and Head of Obstetrics and Gynecology at Government Medical College, Wayanad, to take a session on ELCG and to demonstrate the application. Welcome, ma'am, and over to you.
Thank you very much, Pallavi. Let me share my screen. Hope my screen is visible.
Yes, ma'am.
So today we are going to discuss about electronic labor care guide. So what are the aims of this electronic labor care guide? Definitely it helps in monitoring and documentation of fetal well-being and the progress of labor. And it will guide the health professionals to offer support throughout labor and ensure a positive birth experience. And it would help the health personnel to promptly identify and address the emerging labor complications by providing thresholds for labor observations and trigger reflections, which are specific if the investigation, if there is any abnormality. And it will prevent unnecessary use of interventions in labor and support audit and quality improvement of labor management. So this is how a labor guide would look like, and it is to be entered as soon as the woman comes in labor, and subsequent assessments are entered, and we find that there is an x-axis which will have the time axis and the vertical axis will have the other determinants, and there is a specific space for the second stage. So once it is filled up, it would look like this. And you will see that certain red marks are there. They are the alert marks, and they are shown in this column. So whenever any alert comes, this will be marked red, which will help us to identify the alerts. Now, we need an electronic device, that is the Android application, in which we would enter this. And once we have that, we have a web application and we have a tab application. We first go to the web application and then switch on to tab application once the patient gets into active labor. So in the web application, we have a menu in which we have to enter all the admission details, the patient's name, husband's name, parity, and where she's getting admitted, and whether she is in labor, whether there's a history of previous cesarean section, any ruptured membranes, and whether she has any risk factors. Then we go on to other aspect of supportive care, the fetus, the mother, and the labor progress. So when the patient gets into active labor, we go in for tab application. We have got a username and password to enter this. And once we enter, we have a screen like this, which shows the things to be entered for the fetus, for the women, for the labor progress, for the support care, medication delivery, assessment plan, and we can see the whole of ELCG. Now you would see that there are certain red marks here. These will be blinking in real time when there is time to enter these parameters. So first we come to the companion, that is supportive care, in which we have a column for companion, the oral feeds, the pain relief, the posture, and then to the fetal condition, where we mark the fetal heart rate, the decelerations, the amniotic fluid, the position, the caput and molding, then the pain condition of the patient, her pulse, BP, temperature, urine protein and acetone. Then the labor progress, about the contractions, the duration of contraction, the dilatation and descent. Then the medications which we offer to the patient, like oxytocin, other medications, and the IV fluids. And then there's a column for a planned suggestion where the suggestions are given. And then we have to monitor these patients according to the protocol and enter into these into these columns. So supposing a patient comes to us, we enter in the tab. We can enter by entering the hospital ID. So we can have 4 patients parameters on this tab, and we can click on these tabs and access the patient information. This patient Anaya, her entries have been entered. So we can just click on and enter the tab. Now let us look at the labor care guide. As I told you, the section 1 gives you about details of the identity of the patient, her name, parity, when she started labor. And this is the timeline from 1 to 20 hours, and also the second stage for 3 hours. So this is what I said is the alert line. And the first component being identity, second is the support care. In the support care, we have the companion, the pain relief, the oral fluids, and the posture. If the companion is present, it is marked yes, Y. If it is not, it is N. N is an alert sign. Similarly, pain relief, if not provided, it is N. Oral fluids, if not provided, is N. And the posture, usually all supine posture is SP, which is an alert. Ideally, the patient should be mobile or in a left lateral position. So here we see on the tab, we select the companion and enter the details about companion, pain relief, oral fluid, and posture. And we can go to the next, or we can submit and exit. Then comes the next section, which is the care of the baby. Where we need to enter the baseline heart, the deceleration, the amniotic fluid position, caput molding. So these are the alert signs that when there is baseline bradycardia or tachycardia or fetal deceleration or meconium or abnormal fetal position, caput molding, which will make a red circle. So again, we have to enter on this tab and it will be projected onto the labor care guide. The section 4 is about the women, her pulse, BP, her temperature, and presence or absence of ketones and proteinuria. Again, we have alerts signals, which will be marked red if they are present. So again, we can go and to the tab and enter these. Then is the labor progress. The labor progress, the dilatation, the duration of contractions. And again, we have alerts if the labor is prolonging, the cervical dilatation is not to the expected value. So again, we can enter through this tab about the contractions, duration, cervix, and descent. Next is the medication, what we have used regarding oxytocin or antibiotics or IV fluids, which needs to be entered. So we have the oxytocin medication, IV fluids in the tab to be entered. Then you have the section 7, which is the decision making, where after the assessment, the consultant gives the orders, which is written here and in real time. And the plan is to be taken as to whether we want to wait or we want to accelerate or we want to do a C-section. So this is the plan, which is scroll down, you can find out, and supposing this, whatever you want to mention is not present here, you can put up your plan. Then once the patient delivers, the delivery details are added, the baby details are added, and we can exit. Now, the most important thing is this can be seen by any person at any point of time. The duty emergency is in the theater or the consultant is in her house. She can just log into this application and you can see the condition of the patients on the screen. So the green color tells us that these patients are doing good in labor. The yellow tells us that they are low risk. There are low risk alerts. And the red ones tells you that the high risk alerts, and we can always contact the labor room and find out what is happening to these women. And this is how this will be put up by the Prevent team. There will be a stand and the tab. So one tab can record 4 people's parameters. So to summarize, it is a comprehensive data of labor, can be kept as a permanent record. It has to be entered in real time, and the record starts beyond 5 centimeters. Alerts are helpful in decision making. It can be observed remotely, more useful for decision making as compared to the modified partogram, and an important tool in intrapartum care bundle. So now Dr. Bhamati will give take you through a demonstration of this labor care guide. On to you, Dr. Bambi.
Yeah.
Harini?
Can you see my screen?
Yes.
Everyone. Today we're demonstrating how
Can
to
you see
enter
my
the
screen?
variables into electronic
Yes.
Yes.
Can you hear me? Can you
Yes.
hear this?
labor care guide according to WHO. So this is how our web application looks like. So each intrafetal monitoring nurses, that is IFM sisters, this is a designated team that is assigned for intrapartum monitoring. So these nurses will be given the username and password. So once you enter those credentials, you can sign into our website. So once you sign into our website, so we'll create a hospital ID for each patient and we'll enter the minimum initial required credentials. So this is a training app that we're using for today. So today I'm going to present a hypothetical case scenario, presenting a case of 35-year-old primary gravida, Mrs. Shruti, husband name is Rajesh, admitted to clean labor room. It's a singleton pregnancy with a period of gestation at 39 weeks, 4 days, came with the complaints of labor pain. So current labor, she was in active state when she has come to us. It was a spontaneous onset of labor. There was no history of previous LSAs. It's a primary gravida. She has come to us at 12 o'clock on 21st of January. She had her regular ANCs at a primary health center. It was a booked case. She had pains since last night, and then she is referred from primary health center to the tertiary for further management. So the risk factors here in our case pertaining was elderly primary. She was 35-year-old primary gravida, so elderly primary. The hospital ID is created now. Now we'll move on to the IFM team will enter their username and password. At a time in an app, you can enter 4 patients' credentials. So since we have created an hospital ID, now enter the hospital ID. Once we enter the hospital ID, so we've created Shruti's, Mr. Shruti in our case. So it's blinking there. So these are fake. So once we open that, as you can see here, Mrs. Shruti, wife of Rajesh, and the date of admission and her hospital ID. So this is how the homepage looks like, where it has all the labor care guide components, that is sections of baby details, women, labor progress, supportive care, medications, delivery. And at the end, you can see the assessment, high risk plan, and a cartogram where you can go and see. So this is how a homepage looks like. So here, what we're trying to do is the labor care guide, according to the labor care guide also, the baby details, that is baseline FHS and deceleration and the number of contractions and duration, that is labor progress. Both of these will be monitored every half an hourly. So as you can see, that's how it keeps blinking every half an hourly when it is due for monitoring. And then every hourly will be the supportive care, and every 4th hourly will do PVs, that is per vaginal examination, fetal position, cat foot molding, and pulse rate and BP according to the local guidelines if it is abnormal, and then urine proteinuria if it is case of preeclampsia, and then cervical dilatation and descent. So all of these variables will be monitored every 4th hourly. So this is how the alert will be popping up every half an hourly when it is due for monitoring. So the first section will be the supportive care guide in the labor care guide. So in our case, yes, she was accompanied by her mother, who appeared to be empathetic towards her and who gave her a glass of water. We're just trying to emphasize that she was hydrated. Companion, yes. Pain relief, yes. She has taken tramadol at this point of time. We've given tramadol to her. Oral fluid, yes. Posture is mobile. Anything that is squatting, walking, or left lateral will be mobile again. So we are submitting and we're moving forward. So the next thing will be baby details according to the labor care guide. That is baseline FHS on CTG was 140 beats per minute. There were no decelerations. At this point, we did ARM at the time of admission. And then the amniotic fluid found to be clear. Fetal position was right, occipital posterior. There was no capital molding. Submit and next. Then we move on to the next part, that is labor progress. Contractions, duration of contraction, that is 2 contractions, 30 seconds in 10 minutes. Cervical dilatation was 5 centimeters. Descent is according to per abdomen, that is 3/5 palpable. Submit and next. And then moving forward to women details. Pulse rate, everything was normal in this case. So 86 beats per minute. Systolic and diastolic 110/70 mmHg. Afebrile patient was 36 degrees Celsius. We are recording according to degrees Celsius, not according to the Fahrenheit, which we usually use. This case doesn't have any preeclampsia or any other risk factors. So if this was not done, proteinuria or acetone was not done. If it is not done, you can just tick not done there. Submit and next. Then we'll move on to the medications. Since we've done ARM, we are going to give her antibiotics. That is ceftriaxone, 1 gram Avistar. So once you press those, you can see it. She was already orally hydrating, so no IV fluids given. Now submit and next. Submit and next. So at this point, so since we've entered everything, we are going back to the assessment and plan as you can see at the bottom. So we have 2 risk factors, 2 alerts, that is alerts being occipito-posterior and the low contractions. Okay. Plan will be monitor vitals, watch for progression of labor. Okay, reassess the cervical changes is what it says. Yeah. So next, so once you click the partogram here, you can see all the initials, whatever we have entered, starting from the supportive care to the baby details, and then the women details, that is vitals, and then the labor progression, medications, assessment plan, everything has been plotted, and all the high risk factors have been encircled. They're highlighted with a red color there. Occipito-posterior is highlighted. Then the contractions being only 2 contractions, that is inadequate. So that's why it's getting highlighted there. So after which, so in active phase, every half an hourly, we're going to monitor the fetal baseline, decelerations, and the number of contractions and duration. So every half an hourly, if you forget monitoring, it will start blinking and it will the alert will show. Since we're using a trainee app in a real-time scenario, the web app will pick up the same timings. We don't have to enter like we're doing it today, but this is a training app, so therefore we're entering the timings. So we've entered the timings as 12:30 now. So half an hour monitoring. So like you can see here, Baby and labor progress, both are highlighted in red color. So it basically says that it's time for monitoring. Please enter the credentials. So we're moving forward. So baseline FHS at this point was 140. There were no decelerations. Amniotic fluid was clear. Fetal position is still posterior, occipital posterior. There was no caput or molding. Next. Labor progress. Contractions were 2 contractions. Duration was 30 seconds. She was 5 centimeters. Descent was 3/5 palpable per abdomen. Submit and next. So this is how we keep monitoring every half an hourly baby and labor progress, while every hourly the supportive care, and while 4th hourly the PVEs and the fetal position and caput molding and rest of the things. So moving forward to 4 hours now, after every half an hourly monitoring, the next 4 hours. So by the end of 4 hours, so every half an hourly, the baby details will be monitored. Okay. And then every hourly, the birth companion will be monitored, hourly monitoring, like you can see. And then every half an hourly, the baby details, that is baseline FHS and the decelerations, if any. And then the labor progress, again, every half an hourly. Okay. So this is how the partogram looks like by the end of 4 hours. So now the next recording is at 4 o'clock. So at 4 o'clock at this point, our patient mother felt a little dizzy, and she didn't want to be accompanying our patient. She saw some other patient deliver. She wasn't comfortable with the idea of accompanying her through her delivery process. Patient also denied oral fluids at this point of time because of her pain. Patient remained in mobile position. Submit and next. Baby details were all normal. FHR was 140 beats per minute. There were no decelerations. Right occipital posterior, amniotic fluid is still clear, no caput molding. So after which will be the labor progress. So 4 hours, which with the consent of Mrs. Shruti, we did her vaginal examination. At this point, she was 7 centimeter dilated. Descent per abdomen was 2/5 palpable. Submitted next. Duration of contractions, there was 4 contractions lasting for 40 seconds. So if we see the partogram now at this point, so all of this has been entered. Like you can see, in modified WHO partogram, it basically says 1 centimeter per hour. But according to the labor guide, it basically says if 5 centimeters, you can still wait for 6 hours or more till it goes to the 6 centimeters. And at 6 centimeters, you can still wait for 5 hours. At 7 centimeters, you can still wait for 3 hours to progress to 8. So as you can see, it is still, there's no alert as of now yet. So moving forward, so after 4 hours, after monitoring the FHR half an hourly, along with the contractions and duration, and the hourly monitoring of support. So this is how our partogram looks like. So these were the monitoring which were done hourly. This is half an hourly monitoring which was done. So by the end of it, the assessment is. So there was no pain relief that was given, and there was no birth companion at this point of time. So moving forward, at 8 p.m. now, since I've mentioned, it's a training program. So this website that we're using is a training app. So we have to give the timing and then move on. So like you can see on the screen, the baby details and the labor progress is something that is due for monitoring. So, and the support care hourly. So these are showing the alert signs. So at 8 p.m., birth companion, her mother had went out, right? So her sister has come in now. The patient's sister, Shruti's sister, has walked in, helped her giving back massage. That was the pain relief, form of pain relief, non-pharmacological. Patient accepted oral fluids now. She's taking sips of water at this point of time. Posture is mobile. Submit and next. Then we're going to the baby details. Baseline is 140. There were early decelerations at this point of time. Meconium, there was grade 1. Fetal position, so the rotation had happened to transverse, occipital transverse, from occipital posterior. There was no capital molding at this point of time. Submit and next. We're monitoring the labor progress. Contractions, 5 contractions lasting for 40 seconds, over 10 minutes. Cervical dilatation, she was 9 centimeters after taking her consent for per vaginal examination. She was 9 centimeters at this point of time. Descent per abdomen was 1/5 palpable. So here is how the partogram looks like. So at 9 o'clock, what are the alerts? See, here previously we had these alerts. Now the birth companion has walked in, oral pain back massage, so that was a non-pharmacological form of pain relief, and then the oral fluids patient was starting to accept. So here the meconium stain liquor was one alert, and here the rotation is still happening. So the transverse is still an alert for us, and the rest progress you can see. So the cervical dilatation, like you can compare with the WHO partogram, although it is an alert according to the modified WHO, but according to the labor care guide, it is still normal. It has not come under alert. So moving forward, at 9 p.m. after 1 hour of monitoring. So at this point, so at 9 o'clock, that is after 1 hour, after the monitoring is done, a half an hour for FHS and contractions. So at 9 o'clock, we're going to labor progress. So contractions at this point, 5 contractions lasting for 50 seconds in 10 minutes. She's fully dilated at this point of time. Descent was 0. So when we open the partogram, the second stage by the app has been taken into, the fully dilated has been taken into the second stage. So this is how it looks like in the second stage. So we're going back and we're giving baby details were not entered. So that's how it's alerting us. So baby details were 140 FHS. Early deceleration was still present. Meconium grade 1. Left anterior. No, occipital anterior. Yes. So the rotation is complete at this point of time. There was no caput. There was grade 1 molding. Yeah, submit and exit. So at this point of time, our patient entered into second stage. Now, this is how the partogram looks like by the end of it. So for the next 1.5 hours, our IFM team has monitored fetal heart rate, decelerations, number of contractions, and duration of contractions for every 15 minutes in second stage, like it should be, and supportive care hourly again. So at 10:30 p.m. now, the patient, that is Mrs. Shruti, she started pushing now. So once you press pushing start, once you press that button OK, where it asks you a question mark, are you sure you want to start pushing? So you will start entering the details again. Enter the time at which you have done the next PB for the assessment, that is at 10:30. And we'll record all the baseline FHs, that is 140 at this point of time. Decelerations early was still present. Meconium mild. At this point, you can't assess basically because it was fully dilated. However, fetal position was already, rotation was complete. There was no caput. Molding was, mild molding was present. 1. Submit and exit. We're recording the labor progress here. The contractions were 5 seconds, lasting for 55 seconds, for 10 minutes. Cervical dilatation has already been assigned as fully dilated. Descent is complete. Per abdomen, it was 0.5. Submit and exit. So if you see partogram at this point of time, so hourly support care, companion was present, pain relief was given, oral fluids were given, supine position. So at the end of this recording, so if you see the partogram at this hour, that is at 10:30. So these are the recordings that we've recorded. There were no alerts in the supportive care. Okay, these were the recordings of baseline and decelerations. So to summarize, so the patient was fully dilated, but by 9 o'clock on the partogram. So if you can see the partogram, hourly monitoring, that is supportive care. Then every 15 minutes, the baseline FHS and the decelerations. These was monitored using, this was intermittent auscultation, which we done using the graphic Dopplers. Only when it is required, we do a continuous CTG. And then post which the labor progress, that is the pushing. Here, this is how it is represented. So through the 2.5 hours, this is how the second stage has been represented. So moving forward, at 11:30, patient delivered. So this is how we're going to enter the delivery details. Now the patient has delivered at 11:30. So at 11:30, the patient has delivered. So this is how we're going to enter the delivery details. So mode of delivery will be the patient delivered by vacuum because of the poor maternal bearing down efforts. We did not augment this patient, so no oxytocin. Birth outcome was live birth. It was a female child, weighing about 3 kg. Delayed cord clamping was done, 1 to 2 minutes. Routine care of mother. Yeah, the baby was put on skin to skin contact. Yes. Placenta was complete. Delivered completely. APGA score was 8 and 9. At first minute was 8 and the second minute was 9. Submit and exit. So at this point, if you open the partogram now, okay, once we enter all the details into our tab, all the laboring details and all the delivery details, finally, the web application will have this final partogram, as you can see on the screen. So this is the same case that we've discussed earlier. Mrs. Shruti, wife of Rajesh, who was elderly primary, this was a risk factor in this case, was come to us in active stage of labor from a primary health center for further management. So as you can see, the partogram has all the highlights which are color-coded and encircled around through the monitoring phase, and also the progression of labor, how it has never crossed an alert line according to the labor care guide, okay, and how the descent was smooth enough and how the rotation was normal throughout. And the finally, patient had undergone vacuum-assisted delivery in view of maternal bearing down efforts and delivered a healthy live child, female baby, 3 kgs. So this partogram, what we're talking about is the digitalization of the partogram is basically completely based on labor care guide. So whatever labor care guide has, the same variables is what we're taking. It's a complete replica of the same. And the labor care doesn't have age or period of gestation. So these variables were present and modified but these are not present in labor care guide. But so therefore, whatever is present in the labor care guide is the same application what we're using for the digitalization purpose also. So this was about the briefing of how we've entered so far, all the variables and how we've monitored and how the final effect of the partogram will be seen on our screens. Thank you. So here we're trying to show the differentiation from WHO modified partograph to WHO labor care guide, which is plotted on paper, to the difference from the ELCG, digitalizing the same labor care guide. So as you can see, pertaining to the hypothetical scenario that we were talking earlier, so according to the modified WHO, so this case has crossed alert line and it has gone to action. Okay, but according to the labor care guide, when we have plotted it, it has never crossed the alert. It was within the alert. Okay, so and in the advantage of digitalized partogram is the color coding alerts. Basically, the alerts have been color coded. They've encircled and they've been color coded. And the second thing is that this is all real time. We cannot be retrospectively plotting it, which is very important. And the third part is we can take a printout at the end of the session and we can lessen the burden of documentation. So this is the dashboard of the duty doctor, where the duty doctor, just by sitting in OD theatre, can monitor all the cases that have been admitted to the labor room who've gone into active stage, irrespective of the numbers. And the color coding goes as per the dashboard. As you can see, the green is basically no alert, while the yellow is low alert and red is high alert. So that's how a duty doctor can monitor staying away from the labor room too.
Thank you, Dr. Bhamati, for that excellent steering us through the labor care guide. And the session is open for discussion. Are there any questions, Dr. Pallavi?
There was a discussion in the chat, but no questions as such after that.
Dr. Nurul suggested that baby to be written as fetus. Even I was feeling. Dr. Sudhin says unborn baby. Anything?
Fetus implies that they don't have as much as right as a baby, is it not? Is it like a lesser human being to be a fetus than a baby? Yes, many people don't like this term delivery either. You deliver pizzas, not babies. Babies are born.
Thank you. Thank you for the excellent presentation and excellent session. It was fantastic, and see the advance Prevent has made on this electronic labor care guide. So congratulations to all.
I think there was a question from Dr. Dinesh Paswal. Dr. Dinesh, are you there?
Yeah, I'm there, Dr. Sudhin.
So you are wondering about the changeover from the current government guidelines to the new. Yeah. Yes. What is your view? What do you think are the issues?
So it has a huge implication, let me tell you, because, changing from the partograph, and moving on to I know that this is a much more comprehensive, basically assessment. But then I think, given the situation we are in, we have, 30 million pregnancies and 27 million births. And also at various levels of birth, basically facilities, right from sub-center to primary health center to community health center. Below the district hospital, there is not much of equipments are available where we can monitor. So I think, of course, the government is now focusing more on delivering at basically, CSC or say secondary hospital and secondary and tertiary care hospitals. So I think it will have a, if we move on to labor care guide, it will be a huge shift, and I think there will be a lot of changes which has to be done.
Okay, Dr. Baswal, for people who don't know him, Dr. Dinesh Baswal was a deputy director of the National Health Mission, and he had directed the Lakshya program for India. So we were just looking at the partograms, the labor progression in the PREVENT study so far, Dr. Baswal, and the labor duration is so short. Partly maybe because of the overuse of oxytocin, but we are never getting even anywhere closer to what WHO LG sees, that you can, it's okay to wait longer. And we saw the same thing. Those outcomes are not related to the duration of labor. In fact, most of the ones where adverse outcome was getting, mothers were giving birth within a few hours. I mean, they just had few hours in active phase. But I see what you mean. It's a big change for India when just the national program has been preferred. Sorry.
No, actually, you are right that, we also know that, this augmentation is a very, area which is there, which the government has also seized of the matter, and many times we had also issued guidelines, but that busy labor room, so many deliveries happening. One of the hospital which you are working already, Vani Vilas, I think has more than 20,000 deliveries, if I'm not mistaken. So, these are hospitals where, traditionally, sort of HR is being posted, and, there is no augmentation of the HR. The amount of stress which people undergo, in these hospitals are tremendous. So I think one of the things which I was also thinking that how does it fare when you introduce midwife? Because midwife happens to basically allow the delivery to happen and takes its own course. So how is it? This was one of the questions which was actually coming to my mind. That how does deliveries being conducted by other health workers and deliveries conducted by midwife? Does it make any difference? And when you quoted figure of high income countries versus the low income countries, is it that the midwife is making a difference, or what it exactly is? It is.
Leave that to Prof. Irul to answer, and also your question. I think you are on mute, Prof. Irul.
I think it's an important question. I might ask my mind to go back to my old days in Sri Lanka in the 1970s. Midwives do all the deliveries in Sri Lanka, not only in high-income countries. And the maternal and perinatal mortality in Sri Lanka is one of the best in the region because there are enough midwives. And we had to wait as a medical student, being coached by midwives how to do normal vaginal deliveries, and we had to get 10 deliveries signed up at that time by the midwife. So in terms of the outcome to the baby or the mother, in terms of the labor monitoring was done by midwives, delivery was done by a midwife. In Sri Lanka as well as in UK, there was no difference. So I think what it does is actually it adds human resources, because it's much more costlier to produce a doctor specialized as OBGYN, and whereas here you can give more one-to-one care, or at least one midwife to 3 or 4 women care. So that's a major advantage. You can give a better care with the midwifery. Now, the first question raised was about shift of the partogram to labor care guide. Now the partogram, if you really go historically, was made on Friedman's curve, which was misunderstood by Philpott. And then later on, Zhang found out that we were augmenting too many women. And it is known that in the UK and the USA, more than 66% of medical legal cases of brain damaged children are due to use of or misuse of oxytocin. And I think Sudan group has done a review as well. So the labor care guide gives a provision that you don't start anybody in oxytocin till they are more than 5 centimeters dilated. And even then, even after that, you give more time. So less people are getting oxytocin. And also by using an infusion pump, you will minimize too many contractions and damage. The question mark or the weight on the balance on the other side is, are we going to clog up the labor ward? That's probably the worry of keeping too many people for too long in labor and therefore find it difficult to manage. So that is something which we have to tackle for the sake of preventing damage to the children getting cerebral palsy. And so what we are trying to do is the problem intranatally, we are transferring when they become children and adults as cerebral palsy and epilepsy. So the PREVENT study, if it can demonstrate convincingly by using the labor care guide, you can reduce these incidents and also reduce cesarean sections, because cesarean sections are partly due to fetal distress, partly due to failure to progress. Again, problem related to oxytocin. So if we can demonstrate that, then the government of India and all of us have to think, how do we really transfer or make this definitive change? So because before we can demonstrate, we can't demand that change. So we have to first demonstrate. So hopefully PREVENT might be the first study to show that. And hopefully the future might be bright for more children. Thank you.
Thank you, everyone. So do we have any further questions from the session? Dr. Vinay Chandran. Dr. Vinay Chandran, would you like to come in and ask the question?
Vinay Chandran sir, you can directly ask the question.
Okay.
Yes, sir. Please unmute.
And sir, my question is regarding the ARRIVE study. ARRIVE study says elective induction at 39 weeks. Then one will be forced to use oxytocin for induction of labor. Then PREVENT study and ARRIVE study will be contradictory to each other.
So thank you for the important question. The ARRIVE study is done in a high income setting with facilities for fetal monitoring and also for use of oxytocin. So what we are trying to do is actually to, depending on the circumstances, adopt. And despite the ARRIVE study, NICE, for example, in the UK are not accepted that we should induce women at 39 weeks. Because when you say perinatal mortality is increased by 50% or 100%, we are talking about 1 per 1,000 increasing to 2 per 1,000, but on the other hand, inducing and getting more interventions and also needing more staff. So ARRIVE study is one study, so we had to really wait and see. And there's a recent study published by Malaysian doctors in the Australian New Zealand Journal, similar thing, but they are considered multipare with a favorable score, and they have induced and they have shown that less number of admission to the hospital before delivery, and also there's no difference in outcome in C-sections or the baby's outcome. So studies are coming up, but I wouldn't jump into conclusions right now. So there is a question mark about that. One study showing something in a high income setup, but I will have to wait till what PREVENT shows and then compare these studies. And as you know, actually, the question, Vinay Chandran, you asked also is important, because for a long time, from Matthews Mathai, then a lot of other people have also looked at whether the babies in India mature earlier than the babies of some other ethnic groups and whether we should induce labor at an earlier gestation. These again needs further study. There's some evidence, but there's no total evidence to suggest that we should go for 39 weeks. So I think there is a question mark you can induce, but not as a routine. Routine induction is going to increase additional problems, I think.
Thank you, sir, for the valid information. Thank you.
Thank you.
Any further questions? Okay, there is nothing else in the chat box. So thank you so much, Dr. Jyothi and Dr. Bhamli, for that excellent session.